This presentation offers a brief overview of lumbago sciatica syndrome. Low backache is very common. In fact, it's the commonest cause of absence from work. It can vary in its intensity from being an irritant to being incapacitating. Sometimes low backache can be a harbinger of serious illness. Sciatica implies a neural pain due to compression of one of the branches of the sciatic nerve. Actually, it is one of the roots of the sciatic nerve. Compression, when occurs where the root exits the spinal canal, that is the commonest area. But compression can also occur in some pelvic malignancies, plexopathies, and in perineural fibrosis. Claudication differs from sciatica in that it is not constant. It is pain provoked by exercise. Neurogenic claudication occurs when a nerve is compromised by pressure and there is relative ischemia resulting in ischemia of the nerve when activity occurs and the vascular supply is inadequate to meet the increased demand. Vascular claudication is a different entity altogether where there is ischemia of muscles on exercise. To understand lumbago and sciatica, we must have a brief knowledge or a concise knowledge of spine anatomy. The spinal column is made up of vertebrae. Each vertebra has got a vertebral body. There are two pedicles leading back from the body. And then you have laminae and you have the spinous processes. Transverse processes are at the junction of the pedicles and the laminae. Intervertebral discs are cushions in between the vertebral bodies. Each disc consists of an outer firm annulus fibrosus and an inner soft nucleus pulposus. Ligaments give stability to the spine. There is an anterior longitudinal ligament along the anterior edge of the vertebral bodies, a posterior longitudinal ligament on the posterior aspect of the vertebral bodies, ligamentum flava, which connect the laminae, and interspinous ligaments in between the spinous processes. There are also ligaments which give some degree of support to the intervertebral joints. Muscles add to the stability of the spine, the paravertebral muscles, and these muscles are attached to the transverse processes mainly. The spinal canal is formed by the bodies in front, the pedicles anterolaterally, the laminae posterolaterally. Inside the spinal canal, we have the spinal cord, which ends at the L1 level, and we have the chordae equina below that, which are the nerve roots which exit at their respective foramina. What are the pathologies which affect the spine? There might be bone diseases, metabolic disease, osteopenia or to osteoporosis is the most common, affects older people, people who have malignancies, and people with malnutrition. Infections can affect the bone. In India, the commonest is tuberculosis, the spine. Pyogenic infections can also rarely affect the spine. Trauma can affect the spine. There can be fractures of the spine or there can be dislocations of the spinal column. Compression fractures of the spine involve the body, and these might involve either a wedging of the body or a burst of the body. A wedging is when the shape of the vertebral body is lost to form usually an anterior wedging occurs, and a loss of height of the anterior aspect of more than half is associated with significant instability. A group of fractures are called avulsion fractures. Theodore fractures occur when the longitudinal ligaments, either anterior or the posterior, avulses a part of the bone. This also results in instability. Clay shovelers fractures occur when the interspinous ligaments avulse the spinous process. And transverse process fractures often occur in significant trauma, where the paravertebral muscles avulse the transverse process. The disc can be affected by trauma. There can be a prolapse where the outer annulus fibrosus has a rent and the nucleus pulposus comes out. This kind of a disc prolapse can result in nerve compromise because it can press on the nerves. Disc bulges are a more chronic process where there is a weakening or probably a partial tear of some of the fibers of the annulus. There is no actual protrusion of nucleus pulposus outside, but the disc tends to lose its shape, bulge, and can produce compromise of the foramina, and by itself can produce pain because the disc also has got innervation. Let us classify the clinical features of spinal column disorders into problems because of column instability, problems because of root exit foramen compromise, and problems because of spinal canal compromise. Pain is one of the symptoms. Backache can occur, which can arise from the bone. Fractures, including osteoporotic fractures and traumatic fractures. Infections of the bone result in pain. So do tumors of the bone. Discs are innervated by the sinovertebral nerve of Lashka, and a stretch of the annulus fibrosus, especially close to the end plates, can result in pain. Arthritis or a pathology of the ligaments which support the intervertebral joints can result in back pain. Sciatica syndromes commonly involve the L4, L5, and S1 roots, especially L5 and S1. The pain of an L5 root compromise is usually behind the thigh, along the lateral aspect of the leg, and comes to the dorsum of the foot. The pain of an S1 root compromise is again behind the thigh. Here it is behind the leg and comes to the lateral aspect of the foot or the sole. Clinical features because of a nerve root exit compromise can be motor and sensory. Initial phase usually have sensory symptoms like pain and paresthesia. Later you have motor weakness. L5 root compromise results in dorsiflexion weakness. The L5 root supplies the tibialis anterior, the extensor hallucis longus, the extensor digitorum brevis, and the gastrocnemius, the lateral head. S1 root compromise results in a weakness of plantar flexion. The gastrocnemius, medial head, and the soleus, and some of the abductors can be affected. Cauda equina syndrome classically occurs because of compromise of the spinal canal because of a large prolapse or because of a tumor. You can have weakness of the dorsi and plantar flexures of the ankle. The small muscles of the foot are paralyzed. There is saddle anesthesia, that is paresthesias and loss of sensation along the saddle region, the perineum, perianal, and probably the root of the scrotum. There is also incontinence of urine and stool in cauda equina. Cauda equina syndrome is a surgical emergency, and immediate decompression is essential if we are to try to restore the continence of urine and stool. Management of spinal disorders can be and is usually non-operative. Pain can be managed by analgesics which include NSAIDs, where you feel that there is an inflammatory component, opioids, where the pain is severe, and gabapentin and pregabalin are used to control nerve pain. The second aspect of non-operative management is you want to control instability. This involves augmenting the muscle tone by spinal exercises. Isometric exercises are often preferred because these can provide an increase in the muscle tone without having movement aggravating pain further. Traction has some role in decreasing the pressure on a nerve at the intervertebral foramen. Continuous traction, intermittent traction are both used, and one practical, easy way of giving a person traction at home is by asking him or her to hang from a bar. The weight to the hips and the legs gives traction to the spine. Operative management of spinal disorders includes removal of the compression on the nerve. In cauda equina, you can do a laminectomy, wide laminectomy, and remove whatever is compressing the nerve, whether it's a disc or whether it is a tumor. Otherwise, in a discogenic root compromise, discectomy, including micro discectomies or endoscopic discectomies, and a foraminotomy and drilling of any osteophytes which might be adding to the or contributing to nerve root inflammation is done. The second aspect of operative management is stabilization of the spine. Because once you remove the disc, the height of the vertebral column is significantly compromised at the intervertebral disc level, results in an additional stress on the articular facets. So some people advocate stabilizing the spine in many cases of disc prolapse. So pedicle screw constructs and intervertebral implants, both PLIF and TLIF, have been used or can be used. To sum it up, lumbago sciatica is a very common malady. What produces low backache and sciatica? Compression of nerves and the instability of the spine. What are the management options? You have non-operative management, where you relieve pain pharmacologically, and then you improve the spinal stability. You can also give traction. Surgical management is essential and emergent in the case of cauda equina. Motor weakness also is an indication for early surgery. Sensory symptoms often warrant surgery because it might be very severe and incapacitating, preventing a person from doing whatever he wants to do. The principles are decompression of the neural elements to take the pressure off nerves and stabilizing the spine to prevent further neural compromise and to prevent pain. Approaches to surgery for lumbago sciatica include minimally invasive approaches, including using a microscope or an endoscope. Remember that minimally invasive surgery is by having the smallest possible access through which you can do a thorough job. The pathology should be corrected.